Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 233 of our pharmacotherapy series, which majors in respiratory tract infections. My first question to you reads, JYT is a 45-year-old woman presenting to the emergency department with fevers, chills, and chest pain. Her symptoms have persisted for 4 days, and she has a productive cough with rusty-colored sputum and dyspnea on exertion. She has had no recent illnesses and no known sick contacts, but she was recently released from a 2-year period of incarceration. She has tried acetaminophen to alleviate her fever and chest pain. Past medical history is positive for asthma, for which she is prescribed fluticasone and albuterol, and depression, for which she takes paroxetine. Vital signs reveal a temperature of 40.1 degrees Celsius, heart rate of 128 beats per minute, blood pressure of 130 systolic 76 diastolic, and respiratory rate of 32 breaths per minute with accompanying oxygen saturation of 85% on 5 liters of oxygen by nasal cannula. The remainder of the physical examination is notable for orientation to person but not place or time, and for diffuse crackles bilaterally, which are most apparent on the right side. Her laboratory results include the following. WBC count, 15,500 cells per microliter. Hematocrit, of 29.3%. Sodium of 133 millimoles per liter. Potassium of 3.8 millimoles per liter. BUN of 23 milligrams per deciliter. A serum creatinine of 0.8 milligrams per deciliter. Bicarbonate of 28 milliequivalents per liter. Glucose levels of 148 mg per deciliter. Regarding arterial blood gases, the pH is 7.42, PO2 is 61 mm of mercury, and a PCO2 is 46 mm of mercury. A test for human immunodeficiency virus is negative. Chest radiograph reveals a right lower lobe infiltrate. So my question to you is, what signs, symptoms, and tests are consistent with community-acquired pneumonia in J. Yane's case? In the majority of cases, patients with community-acquired pneumonia manifest with cough with sputum production, dyspnea, and pleuritic chest pain. Patients may show signs of the systemic inflammatory response syndrome, including tachycardia, tachypnea, fever, and an abnormal WBC count. Auscultatory examination often reveals decreased breath sounds, crackles or rhonchi, or egophony in patients with consolidation. Signs and symptoms associated with severe pneumonia are grouped into minor and major criteria defined by the Infectious Disease Society of America (IDSA), American Thoracic Society Guidelines for Community-Acquired Pneumonia. Minor criteria include respiratory rate greater than 30 breaths per minute at admission, ratios of the PaO2 to fraction of inspired oxygen FiO2 less than 250 mm of mercury, systolic blood pressure less than 90 mm of mercury, or diastolic blood pressure less than 60 mm of mercury, confusion, multilobar infiltrates, SBP less than 90 mm of mercury despite aggressive fluid resuscitation, BUN of at least 20 mg per deciliter, leukopenia, thrombocytopenia, and hypothermia. Major criteria include requirement of mechanical ventilation and requirement of vasopressors for more than 4 hours. Clinical findings and a positive infiltrate by chest radiograph or other imaging technique is required for the diagnosis of pneumonia. Patients who are hospitalized based on clinical symptoms absent of positive imaging should have repeat imaging performed 24 to 48 hours post-admission. My next question to you reads, given the clinical condition of JYT in the emergency department, where should her care be continued? The first decision after a diagnosis of community-acquired pneumonia is to determine whether the patient requires hospitalization. Several predictive rules have been developed to facilitate site-of-care decision-making. The two best studied tools that are endorsed by the IDSA-ATS guidelines are the Pneumonia Severity Index, abbreviated as PSI, and the CAB-65 rule. The PSI uses individually scored demographic characteristics, such as age, gender, and nursing home residence, comorbidities, such as liver disease, CHF, renal disease, or neoplasm, physical examination findings, such as mental status, respiratory rate, systolic blood pressure, temperature, and heart rate, and laboratory data, such as sodium levels, glucose, hematocrit, and BUN. The total PSI score categorizes patients into one of 5 classes that are associated with an escalating risk of death. The CAB-65, developed by the British Thoracic Society, is a simple tool that focuses on 5 assessments. They include confusion owing to pneumonia, uremia, that is a BUN greater than 19 mg per deciliter, respiratory rate of at least 30 breaths per minute, SBP less than 90 mm of mercury or DBP less than 60 mm of mercury, and age of at least 65 years. Each criteria receives 1 point, and the cumulative score is associated with a specific, rising with higher score, 30-day mortality risk. Based on the score, subsequent care should be as follows: 0 to 1 is managed as an outpatient, 2 qualifies for admission to the ward, equal to or above 3 qualifies for admission to the ICU for care. Both scales identify patients at low risk of death, but the CAB-65 has been found to be more discerning of patients who need ICU care and with the highest risk of death. The need for ICU admission can be subjective, however, the IDSA-ATS guidelines recommend that patients with 3 or more minor criteria, or at least 1 major criteria for severe community-acquired pneumonia be admitted to the ICU. My next question to you reads, what testing should be performed to obtain a microbiologic diagnosis in JYT? Patient JYT can be assessed as follows using the PSI. 45-year-old woman, 35 points, 45 for age, -10 for gender female, respiratory rate greater than 30 breaths per minute, earns her 20 points. Heart rate greater than 125 beats per minute, earns her 20 points. Temperature greater than 40 degrees Celsius, earns her 15 points. Hematocrit less than 30%, earns her 10 points. And altered mental status, earns her 20 points. A total score of 120 points places JYT In risk strata 4, that is a 30-day mortality risk of 9.3% to 27%, and she should be admitted to the hospital, potentially to the ICU. Using the CAB-65, JYT has a score of 3 and 30-day mortality of 9.2% based on uremia, confusion, and increased respiratory rate, and she should be admitted to the ICU. Microbiologic testing is optional for outpatients with community-acquired pneumonia. However, the IDSA-ATS guidelines recommend attempting to make a microbiologic diagnosis in patients with community-acquired pneumonia who are hospitalized. Microbiologic diagnosis via sputum or endotracheal aspirate can help guide empiric therapy as well as identify rare and usual etiologies and cluster cases. Urine antigen tests for pneumococcus and Legionella pneumophila serogroup 1 are available for patients with severe community-acquired pneumonia. Both tests are sensitive, that is above 80%, and specific, that is above 90%, and have the advantage of detecting pathogens after antibiotics have been administered. The IDSA-ATS guidelines recommend consideration of influenza testing during traditional flu season and during times of an outbreak. Detection of influenza should be via reverse transcriptase polymerase chain reaction, abbreviated as RT-PCR, which is the most sensitive and specific method, with a quick turnaround time for results, 4 to 6 hours. Rapid influenza antigen detection tests may be used, but because of lower sensitivity and specificity, reverse transcriptase polymerase chain reaction is recommended to confirm negative test results reported by the rapid antigen test. Viral isolation in standard cell culture should be routinely performed with respiratory specimens during the influenza season. My next question to you reads, what pathogens are most likely in JYT? The most frequently isolated bacterial pathogen, regardless of epidemiologic factors and severity of illness, accounting for approximately 27% of community-acquired pneumonia worldwide, is Streptococcus pneumoniae. 2 survival strategies are utilized by Streptococcus pneumoniae. The first is related to a non-invasive phenotype that uses surface adhesions, immune evasion strategies, and secretory defenses to promote long-term carriage within the nasopharynx. Deficits in host defense, such as an immunocompromised state, allow colonizing strains of low virulence to cause invasive disease. The second survival strategy depends on efficient person-to-person transmission and associated rapid disease induction by an invasive phenotype. Age younger than 2 or older than 64 years, asplenia, alcoholism, diabetes mellitus, antecedent influenza, defects in humoral immunity, and human immunodeficiency virus infection are risk factors for the invasive pneumococcal phenotype. Other risk factors less likely to be associated with invasive disease include poverty and crowding, cigarette smoking, chronic lung disease, severe liver disease, recent exposure to antibiotics, and chronic proton pump inhibitor use. Following the introduction of the first pneumococcal conjugate vaccine in 2000, that is PCV7, and the expanded PCV13 in 2010, the incidence of invasive disease and all-cause pneumonia have significantly fallen. The advent of these vaccines has not led to a significant pneumonia decline in high-risk pediatric patients, specifically children younger than 5 years with moderate to severe asthma, or asthma with one or more of the following comorbid conditions: heart disease, lung disease, diabetes, or neuromuscular disease. The effect of the newly approved pneumococcal polysaccharide vaccine, abbreviated as PPSV23, on the high-risk populations has yet to be realized. Atypical pathogens, including Legionella pneumophila, Chlamydia pneumoniae, and Mycoplasma pneumoniae, account for approximately 25% of community-acquired pneumonia worldwide. However, atypical pathogens may be present in up to 60% of community-acquired pneumonia episodes because of co-infection. Polymicrobial infection including atypical pathogens may lead to a more complicated course with extended lengths of stay. Several studies have shown that antibiotic regimens that include coverage against these pathogens demonstrate a survival benefit over regimens that do not. Legionnaire's disease, caused primarily by Legionella pneumophila serogroup 1, accounts for 2% to 7% of community-acquired pneumonia. Community-acquired pneumonia caused by Legionella pneumophila is considered to be more severe among hospitalized patients, and it may present with high fever, non-productive cough, low serum sodium concentration, high concentration of lactate dehydrogenase, and low platelet counts. Additional factors such as chronic oral steroid use, that is equal to or more than 10 mg prednisone per day, immunosuppression, and frequent antibiotic therapy will likely place the patient into the category of healthcare-associated pneumonia, abbreviated as HCAP, which will require augmented therapy options. Staphylococcus aureus is recognized as a major cause of nosocomial pneumonia, however, its significance in community-acquired pneumonia is less clear. Traditionally, Staphylococcus aureus has not been considered a common cause of community-acquired pneumonia, that is approximately 2.5% of cases, but it is most likely to occur in association with influenza or in patients with lung abscess. Community-associated MRSA, abbreviated as CAMRSA, is significantly different from the typical hospital-acquired strain. These differences include susceptibility to non-beta-lactam antibiotics, e.g., clindamycin and doxycycline, and clinical syndrome, that is necrotizing radiographic presentation, empyema formation, hemoptysis, and profound hypoxemia, associated with toxins including panton-valentine leukocidin. Toxin-producing strains are also part of methicillin-sensitive Staphylococcus aureus's, specifically MSSA, virulence. The outcomes of patients with MRSA and MSSA community-acquired pneumonia are similarly poor, with prolonged length of hospital stay and a nearly 25% mortality. The influenza A H1N1 outbreak in 2009 highlighted the contribution of respiratory viruses as an etiology of community-acquired pneumonia. Respiratory virus can be the primary cause of community-acquired pneumonia, but it can also be a major contributing factor that predisposes the patient to infection by another pathogen, often bacterial, 11% to 15%. Using contemporary nucleic acid amplification tests, the incidence of viral community-acquired pneumonia ranges from 19% to 32%. Respiratory viruses that cause community-acquired pneumonia include influenza A and B, respiratory syncytial virus, rhinovirus, parainfluenza, adenovirus, human metapneumovirus, and coronavirus. In patients co-infected with both viral and bacterial pathogens, the most common bacteria are Streptococcus pneumoniae, Staphylococcus aureus, and atypicals. Possible microbes causing JYT's community-acquired pneumonia include Streptococcus pneumoniae, Mycoplasma pneumoniae, Chlamydia pneumonia, Staphylococcus aureus, Haemophilus influenza, Legionella species, and respiratory viruses. My next question to you reads, which antimicrobial agent or agents should be chosen for the initial management of JYT? Delayed antibiotic therapy has been associated with an increased length of hospital stay and decreased survival in community-acquired pneumonia, therefore, a rapid and correct diagnosis is imperative. The most recent IDSA/ATS community-acquired pneumonia treatment guidelines recommend the first dose of antibiotic be given in the emergency department in an effort to avoid treatment delays associated with the hospital admission process. All patients should be empirically treated for pneumococcus and atypical pathogens. The choice of the initial regimen should be based on medical comorbidities or epidemiologic factors, including the possibility of antibiotic-resistant causative organisms. Macrolide antibiotics, e.g., azithromycin and clarithromycin, or doxycycline are preferred as monotherapy for non-complicated outpatient treatment and are used in combination with beta-lactams for complicated outpatients and those treated on inpatient wards. Macrolides should not be employed as monotherapy for inpatient care, as nearly 30% of pneumococcal isolates demonstrate resistance. Several mechanisms are responsible for macrolide resistance, including ribosomal modification mediated by ARM, efflux from the bacterial cell controlled by MEF, or a combination of both. Patients with comorbidities, exposure to antibiotics within the past 3 months, drug-resistant Streptococcus pneumoniae risk factors, or who live in an area with a high prevalence of drug-resistant Streptococcus pneumoniae should receive a combination beta-lactam and macrolide regimen or respiratory fluoroquinolone, e.g., levofloxacin, moxifloxacin, and gemifloxacin. Preferred beta-lactams include high-dose amoxicillin 1 gram orally thrice daily, amoxicillin clavulanate 2 grams orally twice daily, or ceftriaxone 1 to 2 grams IV daily. Beta-lactam resistance occurs through alteration of one or more of the penicillin-binding proteins that mediate the bacterial cell wall production. Penicillin-binding protein alterations in resistant strains decrease the affinity to all beta-lactams such that higher concentrations are required for binding and inhibition of the enzyme. Thus, appropriate dosing of beta-lactams in the treatment of community-acquired pneumonia minimizes development of resistance and promotes optimal clinical outcomes. Fluoroquinolones are the preferred agents for community-acquired pneumonia in penicillin-allergic patients. Fluoroquinolone resistance, mediated by mutations in the DNA gyrase gene GYRA, and the topoisomerase 4 genes PAR-C and PAR-E, as well as efflux pump-mediated, has increased because of their widespread use. However, overall pneumococcal resistance rates are low. IDSA/ATS guideline concordant therapy for hospitalized patients has been associated with improved patient outcomes including decreases in time to achieve clinical stability, total duration of parenteral therapy, and hospital length of stay, as well as improved in-hospital survival. JYT's treatment should be started in the emergency department after obtaining a respiratory specimen and pre-treatment blood cultures for gram stain and culture. JYT does not possess risk factors for specific bacteria, such as Enterobacteriaceae or Pseudomonas aeruginosa, therefore, a beta-lactam e.g. ceftriaxone, plus a macrolide e.g. azithromycin should be initiated empirically, both initially given parenterally. Consideration of community-acquired MRSA infection should be made given JYT's recent incarceration and profound hypoxemia, although the rest of her clinical presentation is not compatible with this etiology. The next question reads, what is the appropriate length of therapy for JYT? A definitive duration of treatment for community-acquired pneumonia has not been well established. Significant variation in duration of treatment exists and is independent of severity of community-acquired pneumonia. The IDSA/ATS guidelines recommend treatment for a minimum of 5 days, and patients should be afebrile for 48 to 72 hours before therapy is discontinued. In addition, patients should not have therapy discontinued if they have 2 or more community-acquired pneumonia-associated signs of clinical instability, including temperature of greater than 37.8 degrees Celsius, heart rate of greater than 100 beats per minute, respiratory rate of greater than 24 breaths per minute, SBP of less than 90 mm of mercury, arterial oxygen saturation of less than 90% or PaO2 of less than 60 mm of mercury on room air, inability to maintain oral intake, or abnormal mental status. Evidence suggests that longer courses of therapy, that is longer than 7 days, are no more effective than shorter courses, that is 3 to 7 days. Serial monitoring of infection biomarkers may guide duration of antibiotic therapy. A fall in procalcitonin, abbreviated as PCT, a calcitonin precursor elevated in infection, trauma, and burns, has been associated with a significant reduction in total duration of antibiotic use compared with standard care and may be a useful indicator of adequate therapy. The next question reads, FTE is a 56-year-old man presenting to the emergency department with the complaints of fever, chills, nausea, and vomiting for the last 7 days, and more recently, shortness of breath with productive cough with white sputum for the past 4 days. He visited his family approximately 2 days prior to symptoms, where 2 of his relatives were thought to have an unconfirmed viral illness. Initial assessment reveals the patient to be alert and oriented ×3, but falling asleep during assessment. Pulses present with brisk capillary refill, decreased lung sounds bilaterally, and no peripheral edema. Past medical history is significant for hypertension and diabetes mellitus. The patient has an allergy to penicillin, with a reported reaction of rash. Medications at home include aspirin 81 mg orally daily, hydrochlorothiazide 25 mg orally daily, lisinopril 20 mg orally daily, and atorvastatin 40 mg orally daily. Social history is significant for smoking 1 pack of cigarettes per week. In the emergency department he had a temperature of 38.9 degrees Celsius, heart rate of 112 beats per minute, respiratory rate of 22 breaths per minute, a blood pressure of 126 systolic 80 diastolic, and oxygen saturation of 93% on 2 liters. His laboratory results include the following. WBC count of 2,900 cells per microliter. A hematocrit of 47.1%. A platelet count of 129,000 cells per microliter. Sodium levels of 127 millimoles per liter. Potassium levels of 4.6 millimoles per liter. A BUN of 7 mg per deciliter. A serum creatinine of 0.73 mg per deciliter. And glucose levels of 117 mg per deciliter. Chest radiograph showed bilateral interstitial infiltrates, reverse transcriptase PCR was positive for influenza A. So my question to you is, what is the most likely reason for FTE's influenza infection? Influenza viruses spread when an infected person coughs or sneezes near a susceptible person. The usual incubation period for influenza is 1 to 4 days, and the time between onset among patients who have come into contact with one another is likely to be 3 to 4 days. Adults can shed influenza virus from the day before symptoms begin through 5 to 10 days after illness onset. Young children shed virus several days before illness onset, and they can be infectious for 10 days or more after onset of symptoms. Prolonged viral replication can occur in adults with severe disease, including those with comorbidities or those receiving corticosteroid therapy. Severely immunocompromised persons can shed virus for weeks to months. The next question reads, should FTE be treated with antiviral agents? Patients with laboratory-confirmed influenza virus or high-risk patients suspected of infection should receive antiviral therapy within 48 hours of symptom onset whether or not they are hospitalized. Non-improving high-risk patients or those with symptoms greater than 48 hours and requiring hospitalization should also be treated. FTE falls into the latter category and should be treated for influenza A. Antibiotic treatment is recommended for hospitalized patients with community-acquired pneumonia, even if influenza is suspected, and therapy should be directed at likely bacterial pathogens associated with influenza such as Streptococcus pneumoniae, Streptococcus pyogenes, and Staphylococcus aureus, including Mrsa. And my last question to you reads, which antiviral or agents should FTE be treated with? Influenza susceptibility profiles to antiviral agents evolve rapidly, and treating clinicians should be familiar with updated resistance data found at the Centers for Disease Control and Prevention website, www.cdc.gov/flu. Neuraminidase inhibitors including oseltamivir or zanamivir are the primary antiviral agents recommended for the treatment of influenza. The inhibition of neuraminidase prevents cleavage of sialic acid residues on the cell surface of the virus, thereby preventing the release of virus from infected cells. Considering the high rate of resistance, adamantanes, such as amantadine and rimantadine, are not currently recommended for treatment of influenza. FTE should be treated with either oseltamivir 75 mg orally twice daily or zanamivir 10 mg inhaled every 12 hours. Both medications should be used for a total of 5 days. Neuraminidase inhibitors should be initiated as soon as possible after illness onset, ideally within 48 hours, as this is when the majority of viral replication occurs. However, treatment of any person with confirmed or suspected influenza requiring hospitalization is recommended for up to 96 hours post-illness onset. For patients whose illness is prolonged, treatment regimens may need to be extended beyond 5 days. Development of resistance to zanamivir or oseltamivir has been identified during treatment of seasonal influenza. Oseltamivir resistance is caused by a specific mutation leading to a histidine to tyrosine substitution H275Y in neuraminidase. Oseltamivir resistance, which can occur within 1 week of treatment initiation, has been reported particularly among immunocompromised patients infected with the 2009 H1N1 virus. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 234.